Hello, everyone, and welcome to our virtual Triangle SciTech Expo with the North Carolina Museum of Natural Sciences. My name is Nancy, and I will be your host for the program called PCSK9 Diagnostics, from basic sciences to clinical applications. And with me is Dr. Dayami Lopez. She is a tenured associate professor in the Department of the Pharmaceutical Sciences and a principal investigator in the Bright Institute at North Carolina Central University. She has over 24 years of experience in academic research with a focus on atherosclerosis, breast cancer, and Alzheimer's disease. And her research efforts have been supported by grants from the American Heart Association and other institutions. Dr. Lopez is the founder and the chief scientific officer from the Metabolic Diseases Division of NIFP Technologies. And she is here with us right now. So we usually like to start with an icebreaker question. So just to get the chat going. And Dr. Dayami thought it was a good idea to ask you all, do you have or do you know anybody either in your family or maybe your friends that might have high cholesterol? So you can put that in the chat if you want to. And meanwhile, I just want to kind of give the word to Dr. Dayami. Thank you so much for joining us. We are really, really excited to hear your talk this morning.
Thank you. I'm very happy to be here to talk about some of the work that we do in at NC Central related to high cholesterol. I think a lot of people are interested in knowing how this happened and how much having high cholesterol will affect their everyday lives. High cholesterol is one of the things that when you go to the doctor every year, they want to find out whether you have high cholesterol so you can take the right medications to prevent multiple diseases. But you notice in the title of my presentation, I have this work, PCSK9, and I wanted to just start by saying what PCSK9 stands for is proprotein convertase subtilisin casein-9. It's a very long name, so let's stick to PCSK9. And this is one of the some 9 members of a family of proteins that you will find in your body. And their name convertases are because, of course, they convert something into something else. And these proteins, usually what they do is activate other proteins in your body so they can have the right function. So you don't develop diseases or other factors like that. So most of these members of the family are involved in these different diseases, but in the case of PCSK9, which is the one that we study, is very important for not only to control the cholesterol in your bloodstream, but also to control other diseases like diabetes, hypertension, or high blood pressure. And we will get into that in a little bit. So the icebreaker question was if you know somebody in your family with high cholesterol, and we're going to get into that later. But high cholesterol has actually a clinical name called hypercholesterolemia. Hyper is for high, and cholesterolemia is for cholesterol. And it's actually the primary cause of multiple diseases involve atherosclerosis. And atherosclerosis, we're going to see some pictures later in the presentation, is basically a clogging of your arteries with cholesterol and other lipids, other fats, and that clogging actually prevents the body from receiving the right nutrients and oxygen into the different organs that you have there. There is 3 main types of atherosclerotic related diseases, and we are very familiar with heart disease or cardiovascular disease, which is actually the #1 killer, not only in America, but also worldwide. If you go to the World Health Organization website, you can find that heart disease kills people no matter where they are. So this is not a disease related to just eating too much fat in your diet. Third world countries also people die from heart disease, and diet is not the only factor that could affect. You have to have genetic factors and other factors in your body to cause this. The second type of disease is the cerebrovascular disease, or strokes. That's how we know it popular. Is that actually the #4 killer in America, and then also a big killer worldwide. And peripheral vascular diseases, even though they don't cause many deaths, is very responsible for people being unable to work or doing day-to-day activity, and exercise is an important factor to reduce the amount of cholesterol you have in your bloodstream and then causing these diseases. But if you have peripheral vascular disease, you might not be able to exercise, which makes the whole problem even worse. It's a serious health problem worldwide. In America only, we have currently 93 millions of America, about 38% of the adult population, that has high cholesterol. And this is actually from the current CDC report, and you can look it up on more information about the facts of high cholesterol in the CDC website, which is shown in there. But now there is new recommendation that children should be screened for high cholesterol as soon as 5 years old. And the issue for that is because atherosclerosis is something that start happening from the moment you're a fetus and go on through your whole life. So the older you get, the more problems you're going to have. For some people, because of their genetic background, they will start accumulating cholesterol in the arteries as soon as 5 years old. So I talk a little bit about what is atherosclerosis. Basically, is a clogging of your arteries with cholesterol and other fats. And then what happens is once your arteries are clogged, and you can actually see some of the images here, how this jello substance is accumulated either near your heart vein or in your main artery going to your brain, or even the arteries going down to your legs or even the arms. When that deposit of cholesterol happens, you have very little space in your arteries for blood to go through the different organs and bring nutrients and oxygen. And of course, if that flow of blood is reduced significantly, your organs could start dying off or going to a necrotic stage. And you can see in the first image where it talks about heart attacks, this specific organ have had regions with muscle parts that have died. So you can imagine in the case of a leg, if there is no oxygen or nutrients going to your leg, eventually you will have to, the leg die off and have necrotic tissue, and you have to have an amputation. So basically, atherosclerotic plaque, that's how we call it, that accumulation, and it will cause different issues in your different organs. If you think about it, atherosclerosis is not it doesn't affect a specific ethnic group, or it doesn't affect either male or females independently. Most of the percentage of cholesterol is equally distributed between males and female. There is a specific groups though, like Hispanics, or they have more males than females tend to have higher cholesterol, and in some cases, the Caucasian have more in the females than in male. But in reality, these percentages are not statistically significant. And you can find more of this information on your on the CDC website. Now, I try to summarize in a slide different factors that lead to atherosclerosis, and you can see the very first one is actually high total cholesterol and LDL, which stands for low density lipoprotein. LDL is what we call the bad cholesterol. And you probably hear this word a lot by your doctor or your family member doctor. They say, oh, your bad cholesterol is very high. But we also have to consider factors like triglyceride, which basically all the other fats in your body. So when you eat a fatty hamburger or a steak, you will get into your body not only cholesterol, but also other fats, which are called triglycerides. There is actually also a good cholesterol in your body called HDL, which stands for high density lipoprotein, and actually is considered good because it's the only one that could go into your bloodstream and remove any cholesterol that have been accumulating there. But your doctor would probably say, oh, you need to increase your HDL. And we're working on from a scientific point of view on finding ways to increase your HDL. We have more ways to reduce the bad cholesterol and the total cholesterol than we do for increasing the good cholesterol in your blood. So there is a ratio that you must have between bad and good cholesterol in order to be healthy. So that's why doctors concentrate on that. But if you also suffer from high blood pressure, that's actually very bad for your body because that means your heart is not working properly to pump blood everywhere. And there is a link between the more high cholesterol you accumulate, the higher your high blood pressure, the higher your blood pressure will be. And blood pressure right now is considered causing 2 times the problems for heart disease um, and also strokes. And there is so many groups that actually suffer from more high blood pressures than other. African Americans are between these groups that suffer the most. So we have to have some type of a specific kind of treatment for helping this ethnic group with health disparities. Now, some diseases that you may or may not be familiar with also cause high cholesterol and decreases the good cholesterol, which is diabetes. It's the first endocrine disorder in America. That means one in 3 Americans may suffer from diabetes, especially type 2. Type 1 is more in the juvenile version. That's the one that children need to have insulin and young adults. And of course, it goes through the life span. But type 2, which usually appears in adulthood, this is the one that tends to give you more problems with your cholesterol. Obesity in itself could cause high cholesterol because of all the different changes that occurs in your body due to the excessive amount of fat tissue. And hypothyroidism, which is basically when your thyroid gland stop producing enough thyroid hormone, which is typical in after the age of 40, affects more women than men. We need to also make sure that the person get thyroid hormone supplementation to prevent high cholesterol and then heart disease. And metabolic syndrome is basically when you have multiple of these factors together. So if you have obesity, diabetes, and high blood pressure, automatically you are considered a metabolic syndrome patient, and that will also affect your cholesterol and in general atherosclerosis. Now, not only your genetics or the diseases that you develop because of your genetics may affect atherosclerosis, but also lifestyle factors. So if you smoke, you tend to have more atherosclerosis because of all the problems that cigarette smoke cause in your arteries. And alcohol also gives you problems because it enhances the production of fat in your liver. So that fat will go around your body. And then a sedentary life also cause issues with that. So we have to be physically active. The American Heart Association recommend 30 minutes of exercise every day, at least 5 days a week, to prevent heart disease and a stroke. So like I mentioned, the bad cholesterol is usually the main cause of hypercholesterolemia, heart diseases, strokes, everything related to atherosclerosis. And there is a protein in your liver mainly, but it could be found in every cell of your body called the LDL receptor, but the one in your liver is actually the most important one. And we studied that this protein in our lab in connection to the other one that I mentioned in the title of my presentation, PCSK9. I'm going to go into what is the relationship between those two proteins are. If you have a family member with high cholesterol, you probably hear about them taking high cholesterol, anti-high cholesterol medications, which is called a statin. It could be lovastatin, pravastatin, simvastatin, or they could be the brand name of them. Of those type of medication. So you probably, the person will probably be one of the statin if they found with high cholesterol. And so it basically what it does is it increases the function of you have LDL receptor in your liver, and that would allow your body to get all that cholesterol from the blood, process it, and secrete it out of your body, either through the formation of a molecule called bile acid, which help with digestion, or it could be secreted directly into your feces as cholesterol itself. They are very effective, and most patients do get this drug, but for some patients, the effectiveness of these drugs reduces once the LDL or bad cholesterol reaches certain levels. So that's why you hear that your doctor will put you in one dose of this drug and eventually increase the dose until the patient reach the desired level or the safe level, if we will say. There are side effects associated with this drug. Several patients usually report that they have elevation of a specific liver enzymes, which could be indicated that it's affecting the liver of the person, and doctors will take this very seriously and place the patient in a different type of medication. Or they could develop simply muscle pain, which is called myopathy, which is the doctor can check. But most of the time, they don't get removed from the medication for simple muscle pain unless this muscle pain is very severe. Now, years ago, I started working on the receptor that removes the bad cholesterol. And back then, what we did was we just had rats for our experiments, and we fed them different drugs using for cholesterol treatment before they became very popular. And giving them to the patient, we were trying to identify the mechanism of action of these drugs, and then we were the more of those that drugs that we gave to rats, we noticed that the LDL receptor protein were being broke down or degraded. That's another word that we call it. But the pathway itself was being enhanced. So at that point, we proposed that there must be a protease, which we didn't know at the time. We keep recognizing new proteins and genes involved in this hypercholesterolemia process that was breaking down the LDL receptor due to the high dose of a statin. Now, years later, after I graduated, went on to do my postdoctoral work. PCSK9 was actually recognized as being this protein in 2003 through identification of patients with high cholesterol due to genetic factors, but they didn't have any of the other gene mutations that were known till the point which is actually mutations in the LDL receptor itself. So if you have mutation on that gene, which you can inherit from either your mom or your dad, they usually give you high cholesterol, and you can control it with diet if you have just one mutation. But if you get two mutations from both your mom, and one from your mom, one from your dad, then there is no way to control the disease by doing diet and exercise. You have to do more extreme treatment options to prevent that. So the other mutations that were not at the time was mutation on the bad cholesterol itself. The bad cholesterol molecule is formed not only by including cholesterol, but has other proteins that are important to tell your body when to remove it. And that proteins actually could be mutated, which is called the ApoB gene, apolipoprotein B. And if that protein is mutated, your body doesn't have the ability to remove it. So because these patients didn't have neither of these mutations, they actually went on and did more looking into the genetics, and they found out they have a mutation in this other protein, PCSK9. And right now, you can see the distribution of mutation among patients with high cholesterol. 67% of them have mutation on the gene that removes the bad cholesterol. 14% have mutations on the ApoB gene, which is make up the bad cholesterol molecule. And about 2.3% of the patients have mutation on this newly recognized gene, PCSK9. And other genes that we haven't been able to identify yet will be 16.7%. Every year, we come up with new genes, so to include it in a whole pile of how genetics affect you high cholesterol levels. What is the link between PCSK9 and the LDL receptor? Basically, PCSK9 is the protease that we proposed years ago that degrades LDL receptor due to a statin therapy. And this is one of the reasons why once your body reaches certain level of bad cholesterol, and your doctor increase the amount of a statin you're taking, your body will automatically make more PCSK9, so you can never go more than a certain level. I know this is a complicated slide, but basically what it tries to show you is that basically what happened in the cell, you have your LDL receptor, which is marked by the blue arrows, and binds your bad cholesterol, and it goes inside your liver. There is a part of your cell called the endosome, where basically it separates the bad cholesterol from the receptor, and the receptors get recycled back into your membrane to repeat the process many times, more than 150 times before it gets degraded. And your LDL, or the bad cholesterol, goes into the part of the cell called the lysosome, where it gets broken down by the body, and it could be sent different ways. Now, some of the receptor binds PCSK9 at the plasma membrane, which is identified by the pink circle, and those receptors that are bound by PCSK9 get sent to the lysosome for degradation. So your cell will have to replace them by synthesis of new receptors. And the problem is, if you have more PCSK9 that would normally bind the receptors, then this degradation will be increased, which means eventually your receptor level to remove bad cholesterol will be reduced in the bloodstream. Now, the nice thing about PCSK9 is that we have found patients, at least 2 different patients have been found that they don't have any PCSK9, and the cholesterol level, bad cholesterol levels and total cholesterol level are super low, meaning that we could develop drugs against this molecule to prevent patients from having high cholesterol, and we can treat patients from no matter what type of mutations they have to reduce it. And also when the animal studies were done and the scientists would knock out or remove PCSK9, they also responded better to the different treatment. Now, because of this, two companies, Amgen and Regeneron, developed two inhibitors, which are FDA approved already and also approved in Europe for giving to the patients. It's evolocumab and alirocumab, which are different monoclonal antibodies, which basically what they do, they bind PCSK9 and prevents the degradation of the receptor that removes the bad cholesterol. They have found that patients taking this monotherapy with antibodies, they get 50 to 85% reduction in their cholesterol. In some patients, it's so effective that basically the bad cholesterol almost disappear from the blood, which works better than giving them the statin drug. And even in patients that have mutations for the receptor that have for the bad cholesterol, they get a reduction. And they've seen a modest increase in the good cholesterol, which is a good thing. But the problem is this medication is very expensive. And then you need to be qualified uh, um, by your doctor through your insurance company in order to your insurance company to cover the medication. And that's where our research come in trying to develop tests to identify which patient will better be qualified for the different treatment options. So for several years now, my lab have been working on PCSK9 to find out how do we know how much PCSK9 your body should have. So because of those patients with mutations that led to having almost no PCSK9 in the body, we can infer that it's safe to get rid of PCSK9, but um, the more experiments we do, the more identification of patients with mutations with PCSK9, we have found out that um, uh, there is bad to have low PCSK9. There's also bad to have high levels of PCSK9. So if you have PCSK9 that is overactive, that means it works too much compared to the normal PCSK9, or you have high levels, which could be due to multiple factors like um, gain of function mutation, which basically is mutation that makes PCSK9 more effective on reducing the bad cholesterol receptor, or you having endogenous inhibitors, endogenous activators of PCSK9, or hormones in your body that activate PCSK9. This could lead to hypercholesterolemia and also statin resistant. And you can develop type 2 diabetes, inflammation, hepatosis, hypertension, obesity. So you don't want to have high levels of PCSK9 because of the link to these bad diseases, which I mentioned earlier in my presentation. They lead to atherosclerosis and then heart disease and stroke. Now, if you have on the other end low levels of PCSK9, what have been found, yes, it's safe for your body in terms of reducing bad cholesterol, so it causes the opposite, hypocholesterolemia, but it could cause a statin intolerance. And that means if you do have high levels of cholesterol and you take it, your body will be intolerant of the statin, so you will develop more side effects. But it could also promote type 1 diabetes, neurocognitive diseases, because cholesterol is very important for your brain. And then ophthalmologic eyes problems, because it's important for your vision. And of course, you can develop many infections, including gastrointestinal disturbances, because of the factors that could happen there. And that could happen because a patient might have a mutations that get rid of PCSK9. There is phosphorylation factors, which is modifications of the PCSK9 protein in the wrong way, either phosphorylation, furin, or splicing are different type of mutations or modifications you can do to a protein. And of course, unknown endogenous inhibitors of PCSK9 will also cause these issues. So we're basically concentrating on promoting normal levels of PCSK9 in your body, because they have found that if you have normal levels of PCSK9 in your body, you can have a good response to medications. You don't develop diabetes as a side effect with PCSK9 levels. It promotes healthy lipid accumulations, it promotes brain development, especially the cerebellum, and it protects you against infection and even tissue damage in general. PCSK9 have been found to be important to regenerate your liver, to keep healthy organs. So we don't want to completely get rid of PCSK9. We want to promote normal levels. So even if you do have other issues, that will happen. So two things we have been doing: developing a diagnosis test to identify the levels of PCSK9 so we can advise doctors in which direction they should go, what type of treatment patient will need to have to reduce side effects, and also promote a healthier lifestyle for them depending on the medications they take. And number two, we have been working on identifying endogenous of inhibitors that your body makes itself, so we can use those for developing cheaper and more efficient treatment option with patients with this type of issues. So right now we have two major projects going in the lab related to PCSK9. We have developed a novel diagnostic test, which right now is in the clinical validation part. What it means is we conducted multiple clinical trials with the military personnel from Fort Bragg, the military base here in North Carolina. We also have collaboration with local clinics, and we just recently started collaboration with other universities in other states to really validate that our tests do what we proposing they do. We even have collaboration with Quest Diagnostics, which is a company that do most of your blood work when you go to the doctor. And Quest Diagnostics had provided the original um, funding for this project. And so we have been working intensively in this. So we're close to getting what we need to apply for FDA approval from the federal government so the test could be available to patients. We already submitted a patent application both here and in Europe. So we're hoping we get this very soon. And this is one of the reasons we um, um, developed a new company, Nef Technologies, because this is the purpose of the company, the pharmaceutical company we incorporated, is to actually do the commercialization of this diagnostic test and hopefully the treatments that we would develop in the future. Now, in the case of novel regulation of PCSK9 function, we had identified multiple candidates, and we actually concentrated right now in one of the candidates, one of the proteins that has shown potential to inhibit PCSK9 function without getting rid of the PCSK9 protein itself. And we currently have funding from the federal government to work on this specific molecule, but we have at least 17 different potentially regulators of PCSK9 that we will have identified. So the purpose for that is to provide patients not only with novel treatment option, with cheaper treatment options, so they can actually work on the high cholesterol in a better way that they do right now with a statin causing multiple side effects despite their effectiveness, and the fact that the better drugs, which are the monoclonal antibody, causing issue with financial sense. The insurance doesn't provide yet funding for that unless you have pre-qualified for the antibody. This slide seems to be very busy, but basically here what we include is NIFT, the purpose of our company, which is we seek to help patients suffering from multiple metabolic diseases, not only hypercholesterolemia, diabetes, hypertension, but multiple then. And because we believe targeting PCSK9 is important to control many of these diseases, and because of PCSK9 interact with other proteins uh, and develop specific diseases, we can develop specific treatment for each of those diseases. And basically, we just want to promote healthier life for patients um, and more affordable for patients. So we have a big market size. Like I mentioned earlier, we had 95 million US adults which have high cholesterol. So they could definitely benefit from our uh, products, either treatment or diagnosis test. And right now, the CDC mentioned that only 50% of these people are currently on a treatment option because they have given up on the other medications that they currently have in the market due to side effects. You don't want to get up in the morning with muscle pain and being unable to work or to exercise because of the medication. So they end up giving up and taking the medication, but they are at risk of dying early because of the high cholesterol. About 77% of children already have high cholesterol, and again, it's only going to get worse. And then, so basically, right now, what happens is most patients get put in one medication. If they develop side effects, they get switched to another. That's what we call the try and error method. But our diagnostic tests are shown in clinical trial that can predict which medications are better for this patient without having to go through the side effects. So we can tell the doctor this is more suitable for this patient and they don't have to suffer about that. And the tests that are available right now to identify patients for the most efficient medications are very expensive and not covered by most insurers, whether our test would provide them with a cheaper way to do all of this. So we have multiple solutions. We have submitted different patent applications, not only for the test. So I have included some objectives that we're currently working on is the FDA approval of the assay, developing endogenous inhibitor of PCSK9 into a treatment option for patients, and of course work on more therapies and treatment option for patients suffering from organ injuries and disease, because we noticed that a lot of these factors could also help with that. And we have multiple collaborators. I have slides here. We have Quest Diagnostic is our main collaborator with initial funding. We have clinical trial ongoing with the University of Oklahoma, especially the OBGYN department. We're looking into the effects of PCSK9 during pregnancy. We have collaboration with the Department of Defense, the Womack Army Medical Center. They provide a lot of the subject that we use in our clinical trials. And we have collaboration with BioGreen Synergy. In this case, we just had developed some assay, and we're working on the grant proposal to send some of our research to the space station so they can prove whether our new treatment option that we had developed could help muscle issues in patients. And so we're hoping that we will help astronauts not to get muscle regeneration eventually by going to the space. And then we had the North Carolina Biotechnology Center, who's also have provided some of the funding. And in terms of the business for our NIF technology company, we have a business organization here in North Carolina. We have help from the University of North Carolina, Chapel Hill, which is providing us with training. And then NC State University, which also provide us with developing business plans and how to better be business people, even though most of what I like to do is the science, but the business is becoming an important part of our scientific endeavors right now. So at this point, we could start the discussions of questions. It's this exciting topic for me, but we could be exciting for many people because of how significant is to find at least one family member with high cholesterol.
Yes, exactly. It's such a, current topic, and there's lots of people that either have friends or family members, that are suffering with this type of disease. And it's kind of encouraging that now you've got an possibly like an assay that might be cheaper, and that might be used very early on to kind of detect this that issue. And so we do have a lot of questions, and I can basically group them in three parts, because there are a lot of questions around food, of course,
Uh-huh.
and then an exercise. And then you've got also the block of questions where you actually look at the type of medication that exists now, and what is possible in the future. And then last but not least, we also have a lot of questions about the PCSK9 research itself, because it's so fascinating, right? You still have those 17 options, mutations probably
Yes.
possible that you can investigate. But when was it first discovered? When was it just first obvious that that would be the point to go in this type of disease?
Well, PCSK9, we proposed it in the 90s, but it wasn't being recognized until 2003 when mutations were identified on the gene. So what happened later on, we went back and repeat some of the experiment we done in the 90s and proved that PCSK9 was actually the protease was giving us, or the protein that was giving us the results. And there is a lot of research going on PCSK9. At the beginning, was only related to cholesterol, but as I mentioned on my presentation, it could also be related to Alzheimer's disease, to diabetes, and to hypertension. So there are different mutations identified on PCSK9 which are specific for those diseases. So what happened is we're planning the 17 possibility that we had recognized are related to 17 proteins that interact with PCSK9 on different pathways. So what it does is when PCSK9 is related to hypertension, there will be one of those proteins that mediate what happens to the body that cause hypertension. So we can look into specific treatment for hypertension through that protein. So another protein is related to Alzheimer's disease, so we can look at treatment option for Alzheimer's disease. So it's different possibility of disease-specific treatment that we can develop. Because right now, for example, the statin, which is the medications that is in the market right now, most people get a statin when they have high cholesterol. They also get a statin if they have diabetes, because diabetes leads to not only high cholesterol, but also high other triglyceride, which is other fats, and low HDL. So they have to be put on a statin. That's a recommendation. But statin causes diabetes in itself. So you think, well, how could you prescribe a drug to patients that will make the disease worse? But usually the doctors in that case, what they does is they weigh the benefits versus the detrimental effects. So you either not give the statin to a patient to make the diabetes worse, but they still die from heart disease, or you give them a medication that help them live longer without having heart disease, but the diabetes could get worse. So our concentration will be in finding a disease-specific way through PCSK9 interaction with these other factors that we have recognized to help patients without having to think about, oh, do I have to have muscle pain to save myself from a heart attack? Or do I just have, save my body from a heart attack and I could go by my normal life and exercise, do activities with my children, and do other things, go to work without having to worry about muscle pain. So that's basically what we have been doing in the focus of our research is to finding these different ways to help patients.
Yeah. Yeah. Well, one of that actually leads to one of the questions that we have, because somebody was asking, are there dangers in taking high levels of statins for an extended period of time? And with then, being changing it up with this type of, cure kind of like help or.
Well, the doctor has different ways to check whether taking a statin for a extended period of time is causing detrimentals to it's two tissues, main tissues that could actually three tissues that could be affected by taking a statin for too long. One is your muscle. That's how you get muscle pain. And then second could be your liver. And usually the doctors know that from checking your liver enzyme. And you will notice that if you are taking a statin, they make you take a blood test every 6 months or every year, depending of whether those tests come out right or they're slightly affected. And the third tissue is actually your pancreas. So especially the part of the pancreas that produces insulin. So that's why some of the patients on long-term statin could develop diabetes. First, they start with pre-diabetes and then go into diabetes. Now, a lot of these side effects are reversible. So if you get removed out of the statin, they come back to be better, so they improve, but then your heart problems will get worse. So it's important to be in a medication. Now, whether or not I recommend a long-term medication as a statin is up to your doctor. So, but because they will be the one monitoring. But there are other options, like I said, in the market, like the monoclonal antibodies, which could be, if it properly uh, uh, optimize how much your body itself will need, I will cause better effects. And the good thing about those medications is you could probably need just one injection a year or two injections a year instead of taking a pill every day. It's very difficult for many people to remember to take the pill every day when they go to bed, instead of just having an injection done once a year or twice a year. Now, the problem with those is because one single injection could be too expensive, that is very hard to actually diagnose, for the insurers to say, oh, this patient will benefit from the medication instead of having to take a statin. And that's how our diagnostic test comes along, because we have proven through the research in the lab and also the clinical trial that you can actually predict who could take those medication versus statin. But we still have to go through a lot of approval and also convince companies to start using our test for prediction and on the insurance company. Science is just doing the research. Mm-hmm. Business is mostly convincing a lot of people that what you're doing is the best, so they can go ahead and start using what we provide. So it's a lot of everything. So we have to keep trying and keep proving through research that it actually does what we're saying it does.
Right. Yeah, and I actually have a question. What about natural statins? Because you hear people say sometimes, if you eat red rice or something like that, you might lower your cholesterol. Is that true? Is that something?
Yes, actually, most of the statins came from food. And a lot of them are just a slight modification of the one you get in Reggie's rice. It has a lot of what we call lovastatin. So if you eat in Reggie's rice, you should not take a statin on top of that. Or at least a doctor have to tell you take a lower dose, because that would be, you would be taking too much. And there are a lot of fungus, food related, may have statins in there, or yeast related. So you have to tell your doctor if you're eating those type of food, so you don't get an excess of a statin in your body and end up having side effects, because they will work the same way than the pill. It's just that instead of taking it from a pill, you're taking it with your food. So yeah, definitely.
Which is probably better, right? If you take it from.
Well, it all depends on how much you eat. You don't want to eat too much, because still you're going to increase the levels to high level. So even if you just decide, you tell your doctor, I'm going to eat Reggie's rice instead of taking one of the pills from the market, you still need to go and be tested every 6 months to make sure it's not affecting your liver, your pancreas, your muscle. And watch out for symptoms like muscle pain, and this, gastrointestinal disturbances and things like that. So make sure you don't have any stomach issues or muscle pain, or your skin get yellow. Usually, yellow skin that it gets yellow is usually due to liver problems. So you have to watch out for side effects. Doesn't matter. You can take the pill that the insurance pay for, or you can take the natural nutrients that are there from where scientists isolated a statin they sell to you.
Right. So yeah, that was also one of the questions actually. How often should you be checked for cholesterol? Like once a year, like for a normal person?
If you should, if you don't have high cholesterol, you should be checked once a year. But when you identify it with high cholesterol, then you will need to check every 6 months or 3 months. If you just started a treatment, like the doctor put you on a statin, then every 3 months. If the statin is working the way it should, because remember I mentioned in my presentation that they use a trial and error methods. That means you start a statin, and when you come back in 3 months, if your cholesterol level haven't reduced enough, they will put you in a higher dose, or they switch you to another statin if you have side effects, because not all the statin are the same. There are different molecules and they could have different side effects. So a person may not be suitable for what we call atorvastatin, which is one of the statin they use right now. But it could be suitable for pravastatin. So pravastatin will cause less side effects. Some people have gone through all of the 7 of them that are currently available in the market, and they still develop side effects. So, and they still haven't reached the target level, because the target level usually is less than 200 milligrams per deciliter for the total, and less than 100 for the bad cholesterol. If you don't have any other disease, if you have diabetes or obesity or hypertension, they want you to go even lower to less than 70 for the bad cholesterol. So if you don't reach those numbers with one dose or one type of statin, they might switch it to a stronger one. They might increase your dose, and then the higher the chance for you to develop side effects.
Mm-hmm. Right. Yeah, I also have like a very interesting question. So somebody was asking, does human evolution affect how our bodies process the LDL? Because they're thinking of northern people who subsist on, eating fatty mammals like seals and whales and things like that. So do you think evolution has anything to do with it at all?
Actually, that's a good question, because specifically with PCSK9, we have found there is a huge evolutionary uh, effect on that case, because if you look into the African American, African descendant population, they tend to have loss of function mutation of PCSK9, which means they still develop heart disease, they still could develop high of different type of fats, and which leads to atherosclerosis. But the PCSK9 is less active than it for the European population. So we believe that it has to do with evolutionary factors, because in Africa there was a lot of exposure to different diseases. Remember, I said PCSK9 related to infection diseases. Mm-hmm. So the viruses cause a mutation of PCSK9, leading to this loss of function mutation. Whether in Europe, because they were less exposed to different infections, they developed the opposite mutations that make PCSK9 work better, which is not better for your body, but it's better in terms of its function. So we do have identified that there is a huge evolutionary factor related to how we respond to drugs, and also to treatment options. So it has to do with the mutation that people have developed over the years. Where did they live, what kind of food that they eat, and what kind of activity they do in general. Yes.
Right. Yeah. Yeah, it's such a fascinating topic, and I think we could just go on and on. We have about 6 minutes left. If you have, and maybe we can if you have just a little moment, do you think CRISPR could be a potential, way to kind of like accelerate this whole, you know, process of?
We're actually using it in the lab right now to modify the PCSK9 gene and that other gene that we had identified as a potential modulator of PCSK9 function, because I remember from my presentation, I promote not getting rid of PCSK9, but getting rid of the activities that cause the detrimental diseases, but save PCSK9 for those times that we need PCSK9 to prevent all the problems. So we have been working with Scripps to trying to do that. So we don't have the results yet, so I cannot talk about it, but it will be a good way. And we hope it's doesn't going to happen like in the movies where you use scripts and cause so many issues, but you can actually target specific genes. The technique is developed to target one gene or two genes depending how you use it. So it's not like we risk it to change the whole genetic and make humans into a different human. So, but we have been working on that. I think it's a great idea. And that's one of the things we have been trying to approach in there.
Dr. Dayami, this was so fascinating. Thank you so much for giving this presentation to us all. And thank you all for joining us today. We are at the end of our program, so I would like to thank also our sponsors, the North Carolina Science Festival and Biogen Foundation, and of course, our Friends of the Museum members for all the support they are giving us each and every day. Because of that, we have, we can make these events like this possible. So that is excellent. And of course, we do have some more programs for you. So if you want to check out our website, you can still kind of see what we have for the rest of today and for tomorrow. And also, if you want to see all the other programs, or you want to kind of rewatch this one, we do have all the programs recorded, and they are on our website as well. So please check that out. And so I would thank you again, Dr. Dayami. This was just wonderful. Thank you so much.
You're welcome. I enjoy talking about my research.
Yes. Oh, and I'm thinking that there's going to be lots of, things in the future that will come out of this. And we're so excited to hear about that as well.
Thank you.
So thank you so much, everybody. And I hope you all have a great day. Bye.
Bye.